Welcome to another episode of Progress, Potential, and Possibilities, discussions with fascinating people designing a better tomorrow for all of us. I'm your host, Ira Pastor. Welcome everybody again to another episode of our show, bringing another really fascinating guest today involved in creating a better tomorrow for many people out there. Today we have the honor of being joined by Professor Isabel Oliver, who is the Director General of Science and Research and Chief Scientific Officer at the UK Security Agency, which is a government agency in the United Kingdom. They've been responsible since April of 2021 for England-wide public health protection and infectious disease capability. They replaced Public Health England, and they're an agency of the Department of Health and Social Care. Prior to this role, Professor Oliver was the Director of National Infection Service at Public Health England, having served in various other roles previously in that organization. And she's also a professor and co-director of the National Institute for Health Research, Health Protection Research Unit on Behavioral Science and Evaluation at the University of Bristol. She's also an honorary professor at University College London. Professor Oliver has quite broad research interest, ranging from everything from infectious disease epidemiology, the evaluation of public health interventions and services, to surveillance, protection and control of infectious diseases, environmental hazards, as well as topics like antibiotic resistance, emergency preparedness, sexual health, and mental health impact of major incidents. She led the national study of flooding and health, a really interesting longitudinal study that looked at understanding the impact of flooding on mental health and well-being. Professor Oliver did her degree in medicine, University Complutense in Madrid, went on to the London School of Hygiene and Tropical Medicine at University of London for her master's in public health. And we're honored to have her with us today. A lot of interesting topics to get into. Professor Isabel Oliver, thank you so much for taking the time to come on your show.
Thank you very much. It's a pleasure to be here with you today and looking forward to the conversation. Thanks.
Absolutely, absolutely. It's great having you. I would really like to start off, as we typically do, by giving you the floor for a few minutes, just to further introduce yourself. If you could sort of take us back a little before your bio, everything from your background, where you grew up, and when you first got interested in both medicine and public health. Would love to hear the very early days of this very interesting journey you've been on.
Lovely. Well, thank you. Thank you very much. Well, I was born in Madrid, in Spain, and I decided when I was at school that I was very interested in a career in medicine, particularly because I always knew that I wanted to work in a field where I could help make a bit of a better world, and medicine seemed a perfect way to do that. When I was only 20 at medical school, I met somebody I ended up marrying in Paris when I was learning French, and he was English. We were both learning French in Paris, and as a result, after I finished medical school, I moved to the UK and we got married. A bit young to get married, but anyway, that's the way it goes sometimes. So I've always worked in the United Kingdom, and initially I worked in hospital medicine, in acute medicine, in various hospitals. And it was when I was embarking on a PhD in molecular biology that the professor then realized that my passion really was around public health and epidemiology. I had not known that as a possible career option, having been always working in acute medicine in hospital. I do remember that when I was working in accident and emergency, there was a piece of paper on the wall that said public health, and I knew I had to ring that number when there was a case of meningitis, but that's about all I knew about public health at the time. And yes, I went to find out a bit more about a career in public health and decided that yes, that was for me because I passionately believe that prevention is better than the cure, and that was the way to really make the biggest possible difference in health.
Outstanding, really outstanding. And you know, talking about sort of the early days in, you know, I enjoyed sort of going through some of your early papers while you're with the Health Protection Agency and Public Health England, and you know, you're out in the, we'll say, out in the field a lot in the UK. You know, there's an outbreak of strep A in Wales. You went and checked it out. If there was a well, some of this is non-communicable. There was somebody that ate too many daffodils. There was gastrointestinal poisoning in Bristol. One of the really interesting ones, because I'm here in Philadelphia and I live down the street from where the first Legionnaire's disease outbreak ever was in 1976. You had this issue with Legionnaire's disease popping up in windshield wiper fluid that is inappropriately treated. I love this sort of broad spectrum of non-communicable, communicable things you had to go experience. Talk a little bit about your time in the field, because I think this was it was extremely interesting reading about, but for you, extremely eye-opening in terms of what was happening just in the public health sphere.
Yes, absolutely. And my heart, I think, is still in field epidemiology. So after completing my training in public health medicine, I did take up a post as consultant epidemiologist, regional epidemiologist, looking after the population of the southwest of England. That's a population of about 5 million. And I was responsible for ensuring that we had robust surveillance systems, but also investigating and controlling outbreaks and incidents. And as you say, we take an all hazards approach. So I was looking after both infectious diseases and environmental hazards to health. And that was a really great and interesting time. So it's very varied, but also it gave me a really good understanding of both not just infectious diseases and environmental hazards and the harm they can cause to health, but also the importance of science and research in helping advance the evidence base for protecting health. Because a lot of the time when we respond, let's say if there's an outbreak, it can be a bit late. The outbreak is almost follow this natural history, but it is still really important to undertake a good quality, robust investigation to make sure that we're able to prevent the next outbreak or control it more quickly and effectively. So yes, I've always had that passion for science and evaluation since those days.
Come December of 2009, you published a really interesting paper that could have been written yesterday. Journal of Public Health, entitled "Public Trust is Necessary to Protect the Population from Threats to Public Health." And I believe, you know, this is H1N1 time, I think. And, you know, the messages in this paper, I guess, sort of boil down to, look, good communication is very important to maintaining public confidence in what we're doing as an organization, and to keeping these threats from becoming really big and catastrophic threats. Talk a little bit about 2009 and what was happening when you wrote this paper.
Thank you. Well, for me, it was a tricky time. Of course, when we compare it now with the COVID-19 pandemic, a lot of people think that, it was just a mild pandemic and not a major issue. But at the time, of course, it was a great concern, particularly for me in the Southwest. I was still working as consultant regional epidemiologist in the Southwest, and just taking over as regional director for the Health Protection Agency in the Southwest. And we had the first case in England, the first school affected in England. We had at the time, global media attention. We had a lot of concern in the population, and there was still very limited evidence on the effective interventions to take to control the outbreak. So we still were very much in a containment phase. Mm-hmm. And we had to work to not just reassure the public and mount a public health response, but also generate the evidence that was needed to continue to inform the public health response. And as you say, it's extraordinary, and it is in some ways a reminder that sometimes we don't always learn the lessons that we need to learn very effectively. And going back to thinking about that influenza H1N1 pandemic in 2009, some of the questions that came up during the COVID pandemic are questions that came up then, from should we close schools, how should we manage contacts of cases, all those kinds of questions. But particularly, the issue of public trust in science is one that came up then and was very much highlighted during the pandemic. As we all know, there were very significant challenges in the use and communication of science and how science informed policymaking. And those are areas, where we need to continue to work and improve, because that public trust in science is key to make sure that the uptake of effective public health interventions is as high as possible. Quite rightly, the public desire transparency and information, but there are areas where science is complex, and we always know that risk communication is challenging with subtle nuances that sometimes are difficult to communicate. So deeper engagement with the public and communities is key, and we still don't do as well in this area as we need to. And also ensuring that policymakers engage the scientists as early as possible in the development of policy is also really important.
Mm-hmm. Mm-hmm. And one topic, I guess, also related to this, which again during the current pandemic, fed into that issue of either trust or distrust. It had to do with repurposing. Before we had the vaccines and the antivirals, there was information, let's say, flying around on existing pharmacotherapeutic interventions. Again, at this time back in, this was 2011, I believe, in Emerging Infectious Diseases, you wrote about sort of the study at the time on the use of other types of antiviral drugs to reduce household transmission of H1N1. What were some of your experiences then? Because, repurposing is such a hot topic, not just in terms of people obviously wanting to try things during the pandemic, but it's sort of a pharmaceutical strategy nowadays that we realize we have a lot of pharmacotherapeutics out there that do one thing and may do others. What were you doing when you were looking at repurposing at the time?
Thank you. So at the time, we were assessing the effectiveness of antivirals to reduce the transmission of influenza. And this was looking particularly at household contacts and still thinking about how containment strategy might work. And that study was important in helping identify that actually if you give antibiotics quickly, within 48 hours of exposure, it is possible to reduce significantly by about, well, in our case, by about 92%, if I recall correctly, onwards transmission. So that is really important. And that is absolutely the kind of evidence that we need to be able to mount future responses. As you say, there are interventions sometimes that have been developed, or countermeasures that have been developed with, with a particular problem in mind. But that's one of the wonderful things about science, that we are always building on prior knowledge, and that's one of the things that's difficult sometimes to communicate to the public, because science and scientific knowledge evolves. One of the things that sometimes concerns the public is that, well, something's changed, and of course it changed as our knowledge develops, and we need to do better at communicating that dynamic aspect of science, I think. And then, innovation. As you know, it's not always about coming up with something completely new, blue skies thinking, really disruptive. Actually, often is about considering, solutions for some problems that they have today that have proven to be effective, and to see if we can adapt them to also deal with other problems, for example. And I think that's what we were trying to do with that study. And that is also something that, that was used very much during the COVID-19 pandemic, and proved effective in many areas, both in therapeutics, but also on vaccines. If we had not built on years of research on mRNA for other purposes, we would not have had the vaccines that we had for COVID-19 so quickly available to us, saving millions of lives in the process.
Absolutely. Yeah, absolutely. So with that background, and I appreciate you going into all those topics, let's go into the UK Health Security Agency. Could you talk a little bit, I mean, listening to you and reading about what you've been up to, it's almost, from a United States perspective, it seems like you have sort of a sprinkling of both our CDC responsibilities and our NIH, in the sense there's original research and innovation happening at the same time. So surveillance plus the innovative research. Talk about the organization. I briefly mentioned a little bit about its history in your bio, and just a little bit about what you're, as chief scientific officer. Obviously, everybody ultimately reports up to you in terms of R&D and innovation. What do you do on a daily basis? What's your typical day look like? What are you involved in? Give us a little overview, if you would, of UKHSA.
Oh, well, I can tell you one thing. There is no typical day. Well, one of the wonderful things about the UK Health Security Agency, as you highlighted, is the breadth of our responsibility. So we are responsible for protecting health from infectious diseases and environmental hazards. That includes radiation, chemical, natural disasters, the health effects of climate change, for example. And unlike some of the sort of agencies in other countries with similar responsibilities, we've got a national to local reach. In fact, a global to local reach. So we've got health protection teams and a network of laboratories that provide services at regional and local level. But we also have got the national centers of expertise that provide, the reference and specialist functions and services. So that is really unique, because it means that both in terms of our health protection operations, because we've got that direct responsibility for being a first line of response to outbreaks and incidents, but also our scientific work, generation of the evidence base. We're in a unique position to actually make sure that our scientific knowledge and expertise is embedded into local action, and that is great. I'm very fortunate to lead the science group of the UK Health Security Agency that comprises about 2,500 scientists and other staff covering a very broad range of scientific disciplines. And that is fantastic. And one thing, although there isn't a typical day, what I can say is that every day I'm amazed by the work of our scientists, and there is just such fantastic work going on that every day I get pleasure on that, and that can be from work to do surveillance and better understand how our vectors like mosquitoes and ticks might be changing in the context of a changing climate, to work that looks at, for example, the health effects of air pollution, including wonderful studies about, for example, the effect that air quality can have in subway stations, for example.
Mm-hmm.
Very broad, very fortunate.
Yeah, no, it's and again, I'll be getting into some of the themes some of what you've been publishing about, but yeah, an extremely broad purview. And we will obviously be putting the link to the organization in the bio of the show. Yeah, I'd like to talk about a couple of these topics. I mean, one that we've covered on the show a little bit, which is, a lot of people refer to as the silent pandemic, is this antimicrobial resistance problem that the WHO is projecting somewhere around 10 million deaths a year by the year 2050. I come out of the pharmaceutical industry, and I know we've been doing a very poor job of developing new interventions. Again, here at UKHSA, you have a broad purview of how you look at this. Everything from obviously antibiotic stewardship concepts to surveillance, and then the other end of it, thinking about research and innovation. I read a little bit of your testimony. I guess you were called into the House of Commons a couple months ago. I know it was last year in 2023, Science, Innovation, Technology Committee. You had to give testimony about antimicrobial potential bacteriophage, which really cool topic, old technology, but only beginning to realize the potential in this era of less antibiotics. Say a few words about what goes on at your organization about thinking about AMR.
Yes. So what I didn't say to you earlier is, in a sense, how we protect health from threats in the environment includes, so we prepare to those, we undertake surveillance, we do generate the evidence of what works to protect health against those threats. We build the capacity that's needed to protect health, and of course, we respond to problems when they arise. In terms of antimicrobial resistance, so this is obviously one of the major public health challenges that we face today, and it is one of the priorities for us as an organization. In fact, we are just about to publish our second 5-year national AMR action plan. It's despite the disruption from the pandemic, our first 5-year action plan did secure some advancements in the reduction of antibiotic use, which is really good news. As you say, as a UK Health Security Agency, we are responsible for working with partners to take forward that plan. And that includes from raising awareness among the public, so public information campaigns to make sure that that people understand the risks from antimicrobial resistance, and that we reduce the expectation of an antibiotic prescription when somebody goes to the doctor. But we undertake surveillance to make sure that we understand better what's happening. We do research, as you said, and we contribute to innovation pipelines to assess new antimicrobials. You mentioned new or all therapies adapted to new problems, including the potential use of bacteriophages. We also do research to understand the risk of transmission of antimicrobial resistant organisms in the environment. So one of the things that we have in one of our scientific campuses at Porton Down is a mock hospital ward. Okay. In this is very interesting because actually doing research in hospitals can be very difficult. Because obviously they are always fully active and you don't have a controlled environment. But in this mock hospital ward, and it looks exactly like a hospital ward with a several bed bay and private single rooms and a laundry and all kinds of things. That allows us to do, for example, studies about the risks from resistant organisms through, if they colonize, for example, sinks and drains, how they might be transmitted through surfaces, whether, the contamination is effective, for example, whether different designs of sinks makes a difference in the risk from environmental transmission of these organisms, to actually, laundry and how laundry, different settings, different settings in washing machines can help control these organisms. And then you mentioned, of course, antibiotics stewardship, and one of our priorities is to optimize the use of antibiotics. So we work very closely with the National Health Service to make sure that we don't only have just most appropriate use of antibiotics, but that the antibiotics that are being used are the right ones, to make sure that we are able to preserve the future efficacy of antimicrobials, as well as obviously being able to develop new ones. The other area that might be worthwhile mentioning is that in this new 5-year AMR action plan, one of the things that we are also considering significantly is the potential use of vaccines. And this is, of course, multifaceted. So, for example, clearly vaccines that help reduce the burden of disease, will help reduce the need of antibiotics. For example, one of the major complications of measles is pneumonia. Is bacterial pneumonia. If you are protected against measles, you are obviously you won't suffer that complication of secondary bacterial pneumonia. But also there is interesting developments, and I think we live in a golden era of vaccines. So there are more vaccines being developed than ever, including vaccines against some of the organisms that we know cause particular problems with antibiotic resistance. And within the UK, this is a priority for us in terms of future vaccine development and evaluation. I think the other thing to mention is just the enormous cost that antimicrobial resistance has, both in terms of lives, and I think it was estimated that there were nearly 1.3 million deaths worldwide in 2019 as a result of antimicrobial resistance, and this will only grow. But they have an enormous cost on health and society, because it just means that people have to stay in hospital longer if they have an antibiotic resistant infection, for example, causing significant pressure. So the other thing that we do is is make sure that we work with partners to evaluate novel approaches to help reduce that burden on health services. And I think we also, with the pandemic, also the very effective application of rapid diagnostic tests, point-of-care tests, like lateral flow test devices. And I think there are opportunities to think about how we use these tools and these devices to help us also tackle antimicrobial resistance and reduce burden on the health service.
Mm-hmm. Yeah, it's a scary. AMR is an extremely scary topic personally, but again, you're pointing out the multifaceted nature of how countries need to approach something like that, and it kind of feeds into that topic feeds into where I want to go next, because moving beyond microbes to the broader um, issue of pandemics. And um, you know we learned obviously from COVID that there's a few things that we need in place, all countries, and we just recently talked about this global health security index on the show, namely one, a really good way to rapidly produce or co-produce these important public health interventions, whether they're vaccines or PPE or everything in between, and better surveillance systems. And you've written about both of these. You've written about the Agile co-production evaluation framework, as well as this concept of multi-purpose syndromic surveillance systems that, hey, okay, there's an outbreak of something here, people are coughing, this is the common cold versus the next zoonotic spillover event. Talk about both of these, because these are both extremely critical in a world where, God forbid, but we most likely will have new things happening. Talk about both of these programs. I think they work together and they're extremely important and part of what you do.
Yes, the ACE framework, as we call it, the Agile co-production of public health guidance and interventions with communities is something that we developed as a lesson from the COVID pandemic. I think if I look back at my career a little bit, I think sometimes there's a risk that particularly in health protection, in the context of outbreaks and incidents and emergencies, that when we have to respond quickly, that we think that we're doing the right thing for the population, the right thing for the public, and we need to do it quickly. So therefore, we perhaps traditionally have not been as good as other areas of public health or medicine to engage communities in the design and the development of those interventions, because by nature they're sort of rapid and part of an emergency response. However, one of the lessons from the pandemic is that actually we can do better, and even in an emergency, you can and you should engage with communities. You should work with them to co-develop and co-design public health messages, public health guidance, public health interventions. Because the risks, if you don't, is that those messages won't be effective, or those interventions won't be taken up by everyone. We know we were talking earlier about trust, and we know that trust in science and trust in public health is not equally distributed in populations, and that often those most in need from certain public health interventions are sometimes also the people less likely to take up the public health advice. So this framework is designed to help us develop those interventions together, but also the framework builds in an evaluation. So the word agile, the reason why we use the word agile is to borrow from the work of information technology and software, and that sort of iterative process of developing new tools and systems. And I think we can apply that for public health advice and guidance. So we developed the framework after the pandemic, and since then we have applied it in two situations. One was the Mpox outbreak, right, where we work with affected communities using this framework to make sure that our public health guidance and advice was as effective as possible. And we are currently using it. In fact, only this morning I was reviewing one of the papers we're writing on this. to improve our public health messaging and guidance on avian influenza H5N1. You will be familiar, obviously, with the widespread outbreak in cattle in the US at the moment. We have had a very widespread outbreak in birds for 2 or 3 years now. And as a result, more people are being exposed to the influenza H5N1 virus. The sort of public health guidance and recommendations that we had in the UK weren't being taken up by sufficiently high numbers of, for example, people who work with birds or work in premises where there is an outbreak of avian influenza. So we are using this framework to revise all of our materials and guidance, co-developing and co-designing it rapidly in the middle of a public health response with people who are working in these settings and who we are advising to use personal protective equipment or to take antivirals in certain circumstances, just to make sure that those interventions are as effective as possible. And then you also mentioned syndromic surveillance. So the UK Health Security Agency is a bit of a leader worldwide in syndromic surveillance. We have got a really fantastic surveillance system. So we collect information from accident and emergency departments, from ambulance service providers, from GP consultations, from online services that people call to get health advice. So we bring all this information together to provide us with early warning systems of changes in epidemiology. So we use it, for example, to detect when influenza season is starting or where we see outbreaks of norovirus that can have a significant impact on the health service. So we do give early warning advice to the health service that they might expect an increase in hospital attendances, for example. But we also use it for a whole range of situations. So, for example, is very useful in helping us monitor the health impacts from environmental hazards. And interestingly, we were able, through these systems, for example, to understand better a phenomenon that's called thunderstorm asthma, which might not be very well understood, but we see when there are thunderstorms, this causes a spike in syndromic presentations with difficulty breathing, and it is known to trigger asthma, but we are able to monitor this and again provide advice to the health service that they might expect an increase in admissions, or that to provide advice to the public on making sure that they're able to best protect themselves in these situations. So it's very interesting. We also used it to monitor. It was also very helpful to help us understand better what happened in the pandemic to a whole range of conditions and presentations, and to understand what were true changes in epidemiology and what were changes due to variations in access to service during the pandemic. So it's a very helpful tool, and yes, we're interested also in exploring whether we can add further value to it, for example, by bringing in data on sales of products, not just in pharmacies, but also in supermarkets, so over the counter, from tissues to alcohol disinfectant to over-the-counter medicines. So we're hoping to explore that further to see if we can add even more value to our existing syndromic surveillance systems.
Interesting. Very, very interesting. And I never heard of a thunderstorm related asthma, but that's
Yes.
I learned something new. But no, but hey, again, this sort of feeds feeds into my next talking point, um, about sort of the broader things that you now have to think about, and clearly this March 2022 Lancet paper that you published, entitled "Public Health Institutes in the Fight Against Climate Change," where you researchers from the UK, France, Belgium, United States, talk about now the responsibility of so-called national public health institutes to think about these broader issues. I mean, you brought one up earlier in terms of air pollution, but clearly the fight against climate change impacts everything zoonotic that potentially is going to spill over, heat. And I also, again, I'm coming back to sort of earlier days, but I know this is more mental health care related, but you were involved in this English national cohort study of flooding and mental health. Bring in climate here, bring in the environment and these broader, well, they're not social, but broader sort of environmental determinants of health, and now this responsibility that falls into your lap as well.
Well, I think, climate and environmental change, from my perspective, are, really major issue for us, and they are a priority for the UK Health Security Agency. The reason is that the context in which we are going to have to protect health from infectious diseases and environmental hazards is one of climate change. So we know, and there was a very interesting paper published in Nature, I think, a year ago or so, that demonstrated that I think 58%, nearly 60% of all infections known to affect humans are worsened by climate change. Yeah. There are a small number that are actually improved by climate change, but the vast majority are worsened by climate change. So if we are going to protect health effectively from infectious diseases, we need to understand the threat of climate change, and we need to be able to protect health, understand how to best protect health in the context of a changing climate. The same applies to environmental hazards, although, as you say, in some respects, the evidence base is not as strong in some areas. And this is why we did the national study of flooding and health. So we know that in the United Kingdom, one of the things that we can definitely expect, and that we are already seeing in the context of climate change, is flooding episodes with increasing severity and frequency. And in that context, after some severe floods a few years ago, we were able to reflect that actually we don't often see a lot of acute health effects from flooding because, for example, we don't see a lot of sewage contamination. It can happen, but we don't end up seeing some of the health effects that one might expect in other flooding episodes resulting from sort of, for example, sewage contamination of water. However, we realized that there was no evidence about what are the longer term impacts of flooding on health. We know that people can be affected for a long time. So sometimes people don't recuperate the use of all of the rooms in their home for years. It takes years to deal with insurance claims. All of these things cause a significant amount of stress. And we were able to demonstrate that there is a very substantial impact of flooding on mental health and well-being, right, and that lasts for at least 3 years. And it's important to know this because health systems need to understand, health and, social care and voluntary services, we need to be able to support communities affected. The other thing about climate change is that it often feels like a very depressing topic to talk about. But the UK Health Security Agency, so one of the things I did last year in the context of the publication of our first ever science strategy was the establishment of a new Center for Climate and Health Security. Nice. The reason why I established this was to make sure that we were best able to protect health in the context of that changing climate. The Center for Climate and Health Security published a few months ago a report on the health effects of climate change. This is an extraordinary piece of work. It's a very comprehensive piece of work that provides an analysis of the state of the evidence of the impacts of climate change on health in a number of areas. It's got 15 topics from, flooding, wildfires, chemicals in the environment, vector-borne diseases, a whole range of threats. And the key reflection from me after, having worked with my teams to publish this report is that, in fact, the health impacts of climate change on health, a lot of them can be averted still through mitigation efforts, through progress towards net zero. And a lot of the health effects can be also prevented through adaptation. So we know that we see in the UK increased deaths during heat waves. We know that the distribution of vector-borne diseases is changing, and we are now seeing diseases in Europe carried by mosquitoes such as dengue or chikungunya, right, which were not present in Europe before. But we know that a lot of these impacts are actually preventable if we take action. So we are in the UK Health Security Agency, we're working with local government and local partners to make sure that our communities are as resilient as possible, and that we know what works to increase that community resilience. So I think this is what public health institutes can do, and it's great to see obviously like-minded countries also and partner organizations in other countries working with us on this. We haven't mentioned very much the importance of working globally and internationally, but the challenges that we face today, and we mentioned, climate change, antimicrobial resistance, pandemics, all of these are global health, global challenges, and it's just so important that we work with partners across the world to tackle this, because we know, thanks to scientific advance and innovation, we know we can actually do a lot to protect health against these threats, but we need to work a bit differently.
Mm-hmm. Absolutely. Yeah, and when you mentioned the international theme, I was, because I've been in anticipation of our show, I've been watching the UK HSA sort of press releases every couple of days, and yeah, I noticed a couple of weeks ago you published on the work that you were doing on Nipah, and I was surprising, and because we profiled the group in Bangladesh that specifically was, I think, okay, you haven't had a case, but you're really getting ahead of that one because of the potential again in the cross-border dynamic, and then you have, again, and I recommend for everybody listening and watching to check out the website, because you have reports on obviously flu and unfortunately measles, which is shocking to me that we have this issue popping up all over the place, especially here in 2024. What we have you, what else is coming up that we should know about for 2024 as far as UKHSA, you have conferences, talks, other? Are you going to get called in front of Parliament again to talk about other interesting things? What else is coming up for the schedule that we should know about while we have you?
Interestingly, I am going to Parliament next week to talk about bioengineering and biosecurity.
Important topic.
So clearly this is very topical nowadays in the
Oh, yeah.
US as well as the UK and elsewhere, and you know, following the pandemic. So we have published in the UK a new biosecurity strategy, and obviously the UK Health Security Agency has a key role in this area. You mentioned our work on Nipah. So I'm working, one of the priorities for me is the implementation of our science strategy, and that means really unlocking the potential from our scientific assets to secure better health outcomes. Learning one of the key lessons from the pandemic, which is about the importance of working in partnership with industry and with academia. We have established a new Center for Vaccine Development and Evaluation, and a new diagnostics accelerator to help us advance the work that we need to do in relation to priority pathogens, priority viral families, but also key bacterial diseases that cause AMR, and make sure that we have got the tools that we know we are going to need to protect health from these threats going forwards. So that's very critical for us.
Yeah, it's again, you know, quite a broad portfolio of responsibilities. Clearly, you have a lot on your plate, but again, you've been having such extreme success and building this dossier over the years that make you perfect for this role and the challenges that well, the UK and you know, all of us internationally are going to be facing. So I wish you and the team there the best with it all as you continue to move forward with these programs and protect global health security. So really fascinating work, great story. Again, for everybody that is going to be listening to this particular episode of the show across the various podcast networks, or who will be watching on our YouTube channel. Again, you've been spending time with Professor Isabel Oliver, Director General of Science and Research and Chief Scientific Officer, United Kingdom Health Security Agency. Isabel, again, I want to really thank you for taking the time out of your schedule. I'm glad we got the opportunity to do this. Obviously, thank you for all the amazing work that you do. And as we like to say on our show, you know, thank you for helping to create a better tomorrow for so many people out there, and a safer tomorrow via what you do. Really a great story.
Thank you very much. It's been my pleasure to be with you today. Thank you.